Okay, let's dive right in. We've got some really fascinating source material for you today.
Yeah, this one's interesting.
It's a deep exploration, really, into a specific health issue in dogs and cats. Comes from a veterinary text focused on canine and feline perineal hernia.
Right. Pretty specific stuff.
Exactly. So our mission today is pretty straightforward.
Mm.
We're going to unpack this for you. We want to figure out what it actually is, why it happens, how vets figure it out, and what fixing it involves.
So by the end, you should have a pretty solid handle on this condition.
That's the goal, a genuine understanding. And we'll dig into some specifics from the material, like why is it so much more common in older male dogs? That stood out.
hmm
Hmm.
The signalment is quite striking.
And this thing called retroflexion of the bladder, what does that mean, and why is it such a big deal? An emergency, even.
Yeah, that's a critical point.
Plus, how vets actually, feel for this problem during an exam.
The hands-on diagnosis.
And, maybe a bit frustratingly, what are the chances it comes back even after they do surgery?
Recurrence is definitely something the source addresses.
Okay, let's unpack all of this.
Sounds good. It really gets into the anatomy down there and the challenges when things go wrong. Understanding the why and how is key.
Totally agree. So let's start with the absolute basics. What is a perineal hernia?
Okay, so imagine a sort of muscular wall or floor in the pelvic area around the rectum. It's called the perineal diaphragm.
Right, holding things in place.
Exactly. A perineal hernia is basically when that muscular support structure weakens or, even ruptures,
Just
tears.
like a breach in that wall you said earlier.
Precisely, a breach.
And if that wall gives way, what happens then?
Well, things that should normally stay inside the pelvis or abdomen, like fat, or sometimes the rectum itself, even bits of intestine, or crucially, the bladder, they can start to bulge outwards.
Bulge where?
Under the skin, right near the anus, it's an abnormal pouching out. The core issue, as the text explains it, starts with abnormal function during defecation. Too much straining, maybe? That stress eventually leads to the physical hernia, the bulge.
And you mentioned it can get really serious, that bladder thing.
Yes, bladder retroflexion. That's probably the most acute danger mentioned. It means the bladder literally flips backward and gets trapped in that hernia sac.
Wrapped so it can't empty.
Right. It blocks the flow of urine. That's an immediate emergency. If it's not fixed quickly, it causes huge problems systemically.
Wow.
And beyond the bladder, any organ that pushes into that hernia sac can get stuck. That's called incarceration.
Just stuck there.
Yeah. And worst case, the blood supply to that trapped organ can get cut off. That's strangulation, life-threatening.
Okay, definitely serious. So who gets this? Is there a particular type of dog or cat that's more likely?
The source material paints a very clear picture here.
Yeah.
It's overwhelmingly seen in dogs, older dogs specifically.
Older dogs.
And here's one of the most striking things right up front. The highest risk group is older, intact male dogs, unneutered males.
Ah, okay. So being male and not neutered is the big factor.
Seems to be. It can happen occasionally in female dogs or sometimes in cats, but yeah, that older, intact male dog profile is really dominant in the data.
Why is that? Does the source give reasons?
It strongly suggests hormonal influences. Male hormones seem to affect those perineal muscles somehow, maybe weakening them over time.
Interesting.
Beyond hormones, anything causing chronic excessive straining seems to play a role.
Like what?
Well, for intact male dogs, an enlarged prostate is common, and that causes straining. In cats, they mention things like megacolon, a severely enlarged, constipated colon, or even old pelvic fractures that might have healed badly and narrowed the pelvic canal, making it hard to pass stool.
Makes sense. Anything that makes them push hard repeatedly.
Exactly. And they also mention possible nerve weakness or injury, maybe from something like tail trauma affecting the nerves back there. But that intact male status, it's really highlighted as a primary risk.
Okay, so if you're a pet owner, what are the sort of red flags? What signs should make you think, maybe this is what's going on?
The number one sign is usually straining, difficulty trying to defecate, or maybe even urinate sometimes. Constipation is often the main feature you'll notice.
Right, the pushing. But I was surprised reading the source. It mentioned apparent diarrhea could be a sign, too. How does that work? Constipation looking like diarrhea?
Yeah, it sounds counterintuitive, doesn't it? But what happens is you get this hard, impacted stool stuck maybe further up in the rectum, which might be dilated from the hernia.
Okay.
But behind that blockage, the body still produces liquid feces or mucus. And sometimes that liquid stuff can manage to, like, squeeze past the hard blockage and leak out.
Ah, so it's leakage around the blockage.
Exactly. So you see wetness or discharge, making you think diarrhea, but it's actually a sign of a severe underlying blockage, not true diarrhea at all.
Got it. And then there's the obvious visual sign.
Yes, the bulge itself. A swelling right next to the anus. It might be on one side or sometimes both. In cats, actually, that bulge might be the only really obvious sign you see. Straining might be less dramatic in them sometimes.
Okay, so you notice the straining, maybe that weird pseudo-diarrhea, or you actually see a bulge, you go to the vet. How do they confirm it is a perineal hernia and not, something else? What's the diagnostic process look like?
Well, first, they need to rule out other things that could cause similar signs. The source lists quite a few differential diagnoses things to consider.
Like what?
Could be growths in that area, perineal tumors, benign ones like adenomas or nasty ones like adenocarcinomas. Could be enlarged lymph nodes, maybe linked to anal sac cancer, or rectal tumors themselves. Even things like benign fatty lumps called lipomas or cysts near the prostate, or even just an abscess maybe from an infected anal sac. Lots of possibilities back there.
Right. So do they usually run blood tests? Does it help?
Generally, no. A standard blood work, like a CBC or biochemistry panel, usually comes back normal with just the hernia itself. The main exception, like we talked about, is if the bladder has retroflexed and caused a urinary blockage. Then you might see changes that kidney values, like BUN and creatinine, might be high, showing the kidneys are struggling because of the backup.
Makes sense. What about imaging? X-rays, ultrasound.
Oh yeah, imaging is definitely useful. Abdominal x-rays can confirm if the animal is severely constipated or show if the prostate is enlarged in a male dog. They can sometimes spot enlarged lymph nodes or, in cats, confirm that dilated colon, the megacolon.
And pelvic X-rays.
Those are good for looking for things like old pelvic fractures that didn't heal right, or maybe a mass actually inside the pelvis.
Ultrasound.
Ultrasound gives a better look at soft tissues. Great for getting details on the prostate's size and texture, or for looking right into that perineal bulge to see if there are organs inside, or maybe a hidden mass.
So they've thought about other causes, maybe done some imaging. What's the key hands-on technique the source mentions for really pinpointing the hernia?
Right, the text really emphasizes this. Thorough rectal palpation, feeling inside the rectum. That's absolutely key.
Okay, what are they feeling for?
They're directly assessing the strength or lack thereof of that perineal diaphragm muscle wall. They can feel for accumulated feces, obviously, but also for herniated organs or just that general weakness.
How do they feel for that specific muscle breakdown you mentioned? Is there a trick to it?
There's a specific technique described. The vet inserts a gloved finger into the rectum. Then they gently curve or hook their finger sideways towards the outer pelvic wall.
Okay.
Now, if they can then basically pinch the rectal wall with their finger inside against the skin on the outside, using their thumb externally, and not feel a solid shelf of muscle in between.
Feeling for the gap.
Exactly. If it feels like just skin and rectal lining can be pinched together easily, it means that the muscular diaphragm that should be there providing support has weakened or torn. It's compromised.
That's a really precise diagnostic feel. Clever.
It is. And it's vital they check both sides, right and left. Even if the bulge is only visible on one side, the underlying weakness is often present bilaterally.
Good point. Anything else they check during that rectal exam?
Yes, they also assess the position of the anal sphincter itself relative to a bony landmark called the tuber acei, sort of the point of the hip bone back there. Normally, the anus sits a bit forward and up from that point.
Right.
But with a significant hernia, because the support structure is gone, the whole anus tends to kind of shift downwards and backwards relative to that bone. It loses its anchor.
Okay, subtle clues. And what if they do feel a lump during that exam, not just weakness?
Good question. If they feel a distinct mass, either inside the rectum or maybe associated with the hernia bulge itself, the text suggests further diagnostics might be needed. Things like endoscopy, using a camera to look inside the rectum, or maybe a fine needle aspiration biopsy, using a small needle to get cells from the mass to figure out what it is.
Okay, so let's say the diagnosis is confirmed. It is a perineal hernia. What's the plan? Can you just manage it with, stool softeners or diet changes?
Well, those things, low residue diet, fecal softeners, they might provide some temporary relief from the constipation symptoms, make it easier to go.
So they don't fix the hernia itself?
Exactly. The source is very clear. Those are just palliative. They do not fix the underlying structural defect, the hole in the muscle wall, For that, definitive treatment is needed.
Which is,
Surgical repair of the perineal diaphragm, it's called herniotacrophy, fixing the hole.
okay, surgery. And this is where that link back to intact male dogs gets really critical again, right?
Absolutely crucial. The text makes an incredibly strong point here. For intact male dogs undergoing hernia repair, castration neutering must be performed at the same time.
Not just recommended, but must.
That's the emphasis in the source. It's where things get really interesting because it directly connects that hormonal influence we talked about to the success of the surgery long term. The recurrence rate, the chance of the hernia coming back later, it's significantly higher if the dog isn't neutered.
Wow. So neutering isn't just treating a potential cause, it's also key to preventing it from happening again after surgery.
Precisely. It's considered a critical part of the treatment protocol for intact males, not optional if you want the best chance of long-term success.
Okay, that's a huge takeaway. What about that emergency scenario, the bladder being trapped? How do they handle that before surgery?
Right. If the bladder retroflexion is causing a urinary blockage, that takes immediate priority over everything else. The bladder has to be decompressed, emptied quickly.
Oh,
Usually, they try to gently pass a urinary catheter up the urethra to drain the urine, but if the bladder is so trapped or twisted that a catheter can't get through,
then what?
then sometimes they have to resort to percutaneous cystocentesis. It sounds complex, but it just means carefully inserting a needle directly through the skin and abdominal wall into the bladder to draw off the urine and relieve the pressure.
Okay, direct drainage.
Yeah. And if the blockage has already started affecting the kidneys, causing that isotemia we mentioned, they'll also need intravenous fluids to help stabilize the patient, flush the system, and correct any electrolyte imbalances like high potassium.
Okay, emergency managed or it's a planned surgery. How do they prep the patient right before the operation?
Pre-surgical prep is important. First, they need to gently empty the rectum of any impacted feces. The source specifically advises against using enemas right before surgery,
Why no enemas?
because the liquid from the enema could potentially leak out during the surgery itself and contaminate the surgical field, which you definitely don't want. So gentler manual removal is preferred.
Makes sense. What else?
They'll express and flush the anal sacs, those little glands near the anus. Then they place a temporary purse string suture around the anus
A purse string to close it off.
Yeah, just temporarily during the surgery. It keeps the anus closed tight to prevent any fecal contamination while they're working right next to it. Then, standard stuff. Clip the hair widely around the surgical area, perform a sterile surgical scrub prep, and of course, if the dog is intact, the scrotum is also prepped for the castration part of the procedure.
Got it. All set for surgery. What's the actual repair like? What's the general approach?
Typically, they make a curved incision in the skin just lateral to or alongside the anus over the bulge. Then the surgeon carefully dissects down through the subcutaneous tissue to expose the hernia sac itself, that weakened pouch that's bulging out.
What's usually inside the sac?
The text notes that when they open it, they often find some serosanguinous fluid, sort of a clearish, bloody fluid, and very commonly omentum, which is just fatty tissue that normally hangs down inside the abdomen. Sometimes parts of organs too, as we discussed.
Are there critical things nearby? The surgeon has to be really careful not to damage.
Absolutely. The source highlights the pudendal nerve and the associated artery and vein. These run through the surgical area, kind of crossing near one of the key muscles used in the repair, the internal obturator muscle.
And damaging those would be bad.
Very bad. Excessive dissection or trauma to the pudendal nerve in particular can potentially lead to post-operative incontinence problems, controlling urination or defecation. So careful identification and avoidance is key.
Okay. So what's the main goal of the surgery once they've exposed the hernia?
The goal is to close that defect, that hole or weakened area in the perineal diaphragm securely, but with as little tension on the sutures as possible. Too much tension, and the repair is more likely to fail.
How do they achieve that closure without tension?
A common technique described involves using one of the nearby pelvic muscles, the internal obturator muscle. It lies along the floor of the pelvis. The surgeon carefully lifts part of this muscle off the pelvic bone, the ischium, and essentially swings it upwards or sideways to help fill the defect and provide strong tissue to suture to. It reinforces the closure.
Using existing muscle to patch the hole.
Pretty much. And the text gets quite specific about where the sutures go. It's not just random stitching.
Right, you mentioned reconstructing the layers. How does that work?
It describes placing sutures strategically to bring specific muscle edges back together, essentially rebuilding that supportive wall. They mention sutures connecting, the dorsal top part of the anal sphincter muscle to the dorsal coccygeus muscle, a tail-based muscle. Then the ventral bottom part of the anal sphincter to the medial inner edge of that internal obturator muscle flap they created. And finally, the ventral coccygeus muscle, another tail-based muscle, to the lateral outer edge of the internal obturator flap.
Okay, sounds intricate, like carefully reattaching specific points.
Exactly. It's about anatomically recreating the support structure by bringing those separated muscle boundaries back into apposition.
Got it. Rebuilding the diaphragm.
Right. Once that primary muscle layer repair is done and deemed secure, then the overlying subcutaneous tissues and the skin are closed in layers. And, very importantly, they make sure to remove that temporary purse string suture from the anus.
Can't forget that. What if the hernia is massive or the muscles are just really weak and thin? Are there other options?
Yes, for more challenging cases, really big defects, or dogs with very poor muscle quality due to chronic stretching or underlying issues, the standard repair might not be enough. In those situations, the surgeon might need extra reinforcement.
Like what?
The source mentions using muscle flaps from other nearby areas. The superficial gluteal muscle flap is often recommended, especially in cats or smaller dogs. Sometimes they might use a piece of synthetic prosthetic mesh to bridge the gap, like patching a hole in drywall, or even rotating another leg muscle, the semitendinosus muscle, into the defect to provide bulk and strength.
So several backup plans if needed.
Definitely. And there's also that staged approach mentioned for really complex situations.
Right, especially with the bladder involvement. Can you recap that?
Yeah, for those really large hernias, maybe bilateral ones, or especially when the bladder is retroflexed and causing obstruction, sometimes they opt for a staged procedure. Stage 1 is usually an exploratory ciliotomy opening the main abdominal cavity.
Okay.
From inside the abdomen, they can gently pull the bladder or colon back into their normal position. They might even perform procedures like a colopexy or cystopexy, tacking the colon or bladder to the inside of the body wall to help keep them from herniating again immediately.
And then they wait before fixing the actual perineal hernia.
Correct. They might delay the perineal herniorrhaphy itself for a few days. The idea, according to the text, is that this allows the swelling and inflammation in the perineal area to subside and lets the patient stabilize further, which can actually make the hernia repair surgery technically a bit easier when they do go back in.
Does waiting help the long-term outcome?
Interestingly, the source specifically notes that this staging strategy has not been shown to affect the recurrence rates down the line. It just potentially simplifies the surgical repair itself in those very complicated initial presentations.
Okay, good clarification. So surgery's done, either one stage or two. What does recovery look like? What's involved in post-op care?
Post-op care is focused on pain management and preventing the animal from messing with the incision. Icing the area for the first day or so can help reduce swelling and provide some comfort.
And the dreaded cone.
Oh, yes. An Elizabethan collar, the cone of shame, is absolutely essential to prevent licking or chewing at the sutures, which could lead to infection or the repair breaking down. Good pain medication, appropriate analgesia is crucial for their comfort as well.
What about diet?
They'll usually be put on a moist, low-residue diet or perhaps given fecal softeners. The goal is to keep the stool soft to minimize straining during defecation while the area heals.
Any downside to the softeners?
Well, the text does caution that sometimes stool softeners can make the stool too loose, almost like diarrhea, which can be messy and potentially soil the surgical site, especially if the repair was bilateral and maybe affected sphincter control temporarily. So it's a balance.
And activity. Bed rest.
Pretty much. Strict activity restriction is really important. No running, jumping, rough play. Leash walks only for bathroom breaks. This usually needs to continue for about 3 to 4 weeks to give that surgical repair time to heal and gain strength.
How closely do they monitor the patient right after surgery?
Very closely, especially for the first 24 to 48 hours. The veterinary team will be watching carefully to make sure the animal can urinate and defecate without significant difficulty. A rectal exam might be done again around the time of suture removal, maybe 10-14 days later, if the patient tolerates it okay, just to feel how the repair is healing internally.
And what about preventing it from happening again? We talked about castration.
Right, and that really is the main thing highlighted in the source regarding prevention of recurrence after surgery. For male dogs, simultaneous castration is considered the single most important factor known to reduce the risk of the hernia coming back. It directly addresses that likely underlying hormonal contribution.
Are there other potential complications besides it just coming back?
Yes, recurrence is the main one discussed, but other things can happen. Temporary problems with anal sphincter function can occur sometimes, especially after bilateral repairs. maybe some mild incontinence or difficulty controlling bowel movements initially, often due to nerve swelling or irritation.
Usually temporary, though.
Often, yes. Less commonly if there was very extensive dissection required during the surgery, particularly around that pudendal nerve or deeper pelvic structures, there's a small risk of more persistent fecal or even urinary incontinence. But that's considered less frequent with careful technique.
So, assuming the surgery goes well and complications are avoided, what's the overall expected outcome?
The source indicates that generally the prognosis is excellent. Most animals recover well and regain normal function after successful surgical repair.
That's good
Yeah.
news. But there's still that lingering chance of recurrence you mentioned.
Yes, and the text gives quite a wide range for that risk. It states the recurrence rate can be anywhere from 10% up to maybe 50%.
Wow, 10 to 50%. That is a big range.
Yeah.
Why so variable?
It depends on several things. The presence of underlying conditions that cause straining in the first place, the specific surgical technique that was used, the quality of the muscle tissue available for the repair, how chronic the hernia was, and critically, as we keep saying, whether the dog was castrated or not. All those factors play into that wide range.
That 10-50% figure definitely leaves you thinking, doesn't it?
It certainly does. It underscores that it's not always a straightforward, guaranteed fix.
Okay, so we've really journeyed through this complex topic following the details in our source material. We started with the basic anatomy, understanding that perineal diaphragm and what happens when it fails. We looked at who's most at risk, those older, intact male dogs featuring prominently.
Mm-hmm.
We covered the signs you might see, from straining to that weird diarrhea and the obvious bulge. Then the diagnostic steps ruling things out, the imaging, and that really key rectal palpation technique.
Feeling for the defect.
Exactly. Then the treatment surgery being essential, the critical role of castration for intact males, managing emergencies like bladder retroflexion, the surgical techniques themselves, including those muscle flaps and staged procedure.
Right, down to the suture placements.
And finally, post-op care, potential complications like recurrence, and the overall prognosis. Hopefully, understanding this level of detail helps empower you, whether you face this with a pet someday or you're just curious about how these complex veterinary problems are tackled.
Yeah, it really shows how a problem that looks localized to one spot actually requires thinking about hormones, anatomy, surgical technique, and long-term management altogether.
Absolutely. And brings us back to that recurrence rate, that 10-50% possibility even after skilled surgery, and that undeniable link the source draws to intact male dogs. It really leaves you with a significant question to chew on, doesn't it?
Mm-hmm.
Given these challenges, what further research avenues or maybe different approaches to preventive care might make the biggest difference in actually reducing how often this challenging condition affects our pets down the road? Something to think about.